All right. Good afternoon, everyone. Again, this is Bill Barcelona with America's Physician Groups. We want to welcome you to our joint webinar today with Manifest MedEx, Transform Health, and Choice Physicians Network. I'm Bill Barcelona. I'm going to host today's webinar. And if we can move to the next slide, let me just cover a few housekeeping issues for all of you. All your lines are muted right now. You can submit a question at any time through the Q&A box located at the bottom center of your screen on Zoom. This session is being recorded. It'll be available to all of you via email through a link, and it'll also be available on the Manifest MedEx website after completion. So it'll be shared through social media as well. And today's agenda includes the following 5 items. We're going to talk about the importance of the Data Exchange Framework. We're going to explain to you what a QHIO is, what it does, how it will interact within the Digital Exchange Framework system. We'll talk about the benefits of partnering with Manifest MedEx as your designated QHIO. And we're going to get a firsthand description from Choice Physicians Networks today on their participant perspective with Manifest MedEx as a QHIO. So it'll give you a good handle on how all this works. And then lastly, we'll have time for Q&A. So with that, I'm going to turn it over to my colleague, Lisa Chan-Sawin from Transform Health.
Thanks, Bill. Can everybody hear me okay? Fantastic. It's really great to be here with all of you to talk about data sharing and the Data Exchange Framework. Next slide, please. So here in California, we have some big, bold plans for transforming healthcare, expanding coverage, and improving the connections between health and social services entities. As you can see from your screen, the state's vision is that all providers and payers be in the same ecosystem, sharing data to better support patients and improve outcomes. The ultimate goal of what we're trying to do with health information exchange through the DxF or the Data Exchange Framework is to support the whole person in their health and health-related social needs and preferences. So when we look at this image, we really see the patient, the providers that are supporting the patients at the center. And the idea is that data will be able to flow seamlessly to streamline coordination of care with many of your other surrounding entities, providers, payers, CBOs who are engaging and supporting the same patient. And many may be wondering, well, how does this fit in the larger, bigger picture, particularly if I'm an organization that extends beyond California? Well, nationally, we have the Trusted Exchange Framework and Common Agreement, also known as TEFCA. And TEFCA is intended to improve electronic interoperability among health information networks and to support and facilitate the exchange of health information amongst connected organizations. What's really fantastic is California has truly embraced where nationally we are headed. And so the data exchange framework that has been designed and stood up here in California really follows in lockstep with where we're going nationally and what the bill looks like across the nation. Let's see. A few things. The data exchange framework certainly is the first step towards this vision by agreeing to the rules of the road and to use securely exchanged data. It really brings together existing standalone health systems, providers, and also the county and social service providers together to have the right data at their fingertips to seamlessly support their patients and improve outcomes for all Californians. The DxF aims to fill in gaps of understanding about social determinants of health. It is intended to enable our health and social service providers to support and address health inequities and disparities, especially in historically underserved and underrepresented communities. And so the thinking is an interoperable health IT ecosystem that makes the right data available to the right people at the right time across products and organizations in a way that can be relied upon and meaningfully used by providers and by patients will help improve patient outcomes. And this learning health system should enable us as a community and as a state to lower healthcare costs, improve population health, empower consumers and patients, and identify and address health disparities and drive innovations. And certainly, many state agencies have started moving in this direction as well. Last year, we saw the California Department of Public Health sent letters to all healthcare facilities in the state, urging them and reminding facilities that they are expected to adhere to the data exchange framework and sign the state's data sharing agreement and the like. We also saw the Department of Healthcare Services take action as well. They've started working with plans to understand the footprint of which providers in plan networks have signed the DxF and how we can encourage and bring everybody along into that same ecosystem. Next slide, please. So let's take a moment and talk about what AB 1333 set the stage for in California. So the data exchange framework has two components. There's a data sharing agreement, oftentimes called the DSA, and a set of policies and procedures, which are referred to as the P&Ps. Both the DSA and these P&Ps were developed to align with and build upon existing state and federal data exchange laws, regulations, and initiatives where possible. So it really does look into and take into account HIPAA, TEFCA, CalDRSA, some of these other rule sets that are impacting our collective ability to engage and exchange data. The DSA is a legal agreement that healthcare organizations are required to sign. It highlights key legal requirements for data exchange. The P&Ps are truly at heart the rules in the road and guidance to support on-the-ground implementation. And both are incredibly important as organizations begin their DxF journey. The DxF, just so we're all on the same page, is technology agnostic. It's not a technology system or a single repository of data. What the data exchange framework, the DxF, does is it brings everybody together and sets the common rules of the road so that everyone can seamlessly provide better care and exchange data together. A key part of this implementation includes unique, secure digital identities capable of supporting the identification of patients and ensure that they're linked correctly to their providers. Signing the data sharing agreement is just the first step. So let's take a moment, next slide, please, and look at what this journey looks like. So we spent the last year talking to providers, hearing about what their journeys look like, and we distilled what we commonly heard into 8 common steps around how to get from signing the data sharing agreement to fully being able to exchange data. And so you see those 8 steps here. You know, initially, we always see providers, plans, CBOs, all entities seeking to learn about the DxF, what their requirements are, checking if they are a required signatory, talking to leadership, all leads towards helping your organization understand what is required under the data exchange framework and what it means to sign the state's data sharing agreement. once the data sharing agreement is signed, many organizations then pivot to planning for implementation. There are quite a few steps there to truly understand who your trading partners are upstream and downstream. And certainly we saw many entities seek funding to support their ability to implement these changes. And by planning and thinking through with your trading partners how you want to exchange data and receive data, we see many providers creating these internal changes to their electronic systems, their workflows, updating their policies, procedures to support their ability to begin exchanging data. Next slide, please. All of this information we have coalesced into an implementation toolkit. This toolkit walks organizations through the process of understanding what they are being asked to sign, as well as what does the implementation journey look like. For each of these 8 steps, what are the key questions to discuss internally within your organization, outlining your planning steps, and includes a list of questions to discuss with your trading partners, and any entity that you're seeking to exchange data with. We will share the toolkit with everyone, and we are also expecting CDII to make they liked the toolkit, so they're going to take it and issue CDII sponsored toolkit. They gave us the funds to develop this toolkit last year. And so we're really excited to be able to share this with everyone. Next slide, please. And for anyone who would like a copy of this toolkit, as well as to be on our mailing list for when the CDII toolkit comes out, this is our email. We're happy to share the toolkit with any organization who is embarking on this journey and welcome feedback and comments on it. We take all the feedback seriously and we'll be sharing that with the state as well as they develop a CDII specific toolkit. So
Thanks,
I'll turn
Lisa.
it back over to Bill.
So the toolkit is a very important resource for everybody to access. It's free, it's comprehensive. Soon it'll be endorsed by the CDII. And it is a very useful first step for your journey here on the Digital Exchange Framework. Now, we're going to turn to the next segment of this webinar. And I want to introduce our next 2 speakers. If you can change to the next slide, Beverly. Thank you. We're going to talk about how Manifest MedEx as a QHIO can help you meet your DxF requirements. And we're going to feature one of our APG members, Choice Physicians Network. And let me introduce Justin Ash, who's VP of Information Technology at Choice Physicians, and also Felix Su, who is Director of Policy at Manifest MedEx, to walk you through the experience of what it's like to be a physician group who is contracted into the Manifest MedEx portal with for DxF connectivity. So, gentlemen, please go ahead.
Thank you so much, Bill. And I am really happy to be here and I look forward to the discussion, obviously, with Justin and your questions. So we can go on to the next slide in this section, please. So obviously, we're Manifest MedEx. We call ourselves MX for short. And we are the largest nonprofit health data network in California. Now, since 2019, we've nearly quintupled the number of healthcare organizations that are contributing data through our platform. We aggregate this data across our network to form comprehensive records for 38 million patients. And these are highly integrated in the sense that they combine both clinical and claims information for over 3/4 of those records. And we paired the delivery of these records with over 1.5 million real-time notifications of what are known as admit, discharge, and transfer or ADT events on a monthly basis from hospitals throughout the state. Next slide, please. So where do all these records come from? Our network spans over 100 hospitals and over 1,000 ambulatory provider groups, which of course is essential for sharing clinical patient information. But additionally, and uniquely amongst other health data networks, we also have 16 major health plans that are contributing claims and encounters to us to really complete the picture for a true longitudinal health record. And it's through this breadth and depth of data that we are able to have statewide capacity, as you can see from this heat map, which approaches 100% coverage for certain key counties in terms of the populations that we have this vital information for. We are able to get clinical data flowing to such a diverse set of stakeholders through two main types of connectivity. First, we are able to establish data feeds from over 70 different types of EHR systems, which is why we can so quickly and successfully onboard providers to begin directly sharing data in our platform. And second, we are full-fledged members of the eHealth Exchange, which is a nationwide network for sharing clinical documents for care coordination. Now, we don't just prioritize the sheer volume of data that we make available. Even more importantly, we are laser focused on the reliability and security of that data, which of course constitutes PHI or protected health information for millions of Californians. The two logos on the bottom right of the slide here represent the Gold Star industry certifications in data security and reliability that we have earned for multiple consecutive years, which are the High Trust certification for security and also being an NCQA validated data stream. And of course, our most recent distinction, the topic of today's webinar, is being a qualified health information organization or a QHIO for the DxF. Now, to really grasp and appreciate what being a QHIO means and how it can serve as a resource to comply with and benefit from the DxF, I first want to do a very quick overview of what the DxF actually is and what it requires at a very basic level for your organizations today. Next slide, please. So I promise that this is not going to be a long, comprehensive seminar of all the detailed requirements of the DxF. What I will try to do is boil it down to the classic fundamental questions. Who is subject to the DxF policies and requirements? What data must be shared? And why, when, where, and how are you supposed to share that information electronically? Next slide, please. So the first question, who is subject to the requirement to sign the data sharing agreement and to comply with the PMPs? The organization types are actually spelled out in the original statute of AB 133. In most cases, if you are a hospital, a health plan, a clinical lab, a skilled nursing facility, or a physician organization, you had to have signed the DSA over a year ago. And a little less than a month ago, you were required to actually begin exchanging or making available electronic health information according to its terms and conditions. Next slide, please. So what data must be shared? Here we can see the general type and content of the information that you are required, if you maintain that information, to exchange or make available under the DxF. This is known as the United States Core Data for Interoperability, or the USCDI for short. And the DSA also lists the technical formats that are needed to properly transmit the required data elements. Many of you are probably familiar with sending and querying health records using CCDAs and also increasingly FHIR APIs. So the DxF policies require that you use at least one of these formats, HL7 messaging, CCDA, or FHIR to exchange and make available the information that you maintain in the USCDI. Next slide, please. Now, for many health plans, which are also required to execute the DSA, you probably maintain large sets of clinical information for care coordination, quality improvement, and other healthcare operations. In that case, the DxF requires payers to share that clinical data that you maintain, again, according to the USCDI, alongside the more traditional administrative data sources like claims and encounters. Next slide, please. So I mentioned healthcare operations. That is one of the specific purposes that is required for data sharing under the DxF, which brings us to the broader question of why, or I guess more precisely, for what purposes data must be shared under the framework. Now, the policies in the DxF leverage the federal HIPAA definitions for the 4 key purposes: treatment, payment, healthcare operations, and public health activities. When must you share for these purposes? If you sign the DSA, then you have a duty to electronically respond and send the relevant information that you maintain whenever it's requested by another DSA signatory for one of these required purposes, as close to real time as possible. Now, a key sub-requirement that pertains to hospitals is to send ADT notifications whenever requested for any panel of patients by another signatory of the DSA. Where do you go to initiate a request for information? The state recently launched its DxF participant directory, which is a public listing where all signatories are required to enter their choice of technology for how they will receive both the requests for and deliveries of information under the framework. How must these requests be responded to and received from a technical standpoint? The policies cite certain profiles that govern how the DSA signatories must digitally construct how they send these requests and responses for information, and also how they properly match the request to the proper individual that's being looked up under the information delivery. Next slide, please. So if you're one of these, the who that I went over, that is, you're one of these newly required participants in the data exchange framework, how do you know which platforms or networks that you can rely on to meet all of these various obligations in terms of the what, the why, the when, the where, and the how? Well, that's where QHIOs come in. Now, the QHIO is a DxF-specific designation. There are currently 9 data networks, including MX, which have applied for and have received this designation for having met the specific requirements from an organizational, privacy, security, and functional capability standpoint. You are not required to join or use a QHIO to fulfill your DxF obligations. You can use any technology or network or intermediary of your choice. You can even use your own individual point-to-point connection if that fits the scope of your needs to comply with the DxF. Next slide, please. Now, all that said, we do think there's a very compelling case to consider partnering with a QHIO and with MX specifically. And to understand why, I want to return to those classic questions to explain our services and capabilities. So in terms of the who, we at MX have made very important investments to expand and scale our capabilities to serve as a QHIO for all types of DSA signatories. Certainly all the types that are represented in the audience today, regardless of the geography or resources or size of the organization. In terms of the what, our investments include a series of enhancements to ensure that we are ready to receive and transmit all of those USCDI data elements that you're required to share under the DxF. Since the beginning, we have been actively exchanging data using HL7 messaging and the CCDA standards, and we've also developed our FHIR capabilities. In terms of the why, we are set up to allow any other signatory to query us for those longitudinal records based on the 4 required purposes. In terms of when, we will respond to those requests on your behalf in a timely manner as specified in the DxF policies for real-time exchange. And crucially, we have statewide capacity, again, to receive and match and forward those mandatory ADT notifications that are triggered by a hospital event. In terms of where, if you join our network, as long as you enter us as your choice of a QHIO in the participant directory, we are going to be able to provide any connection point that's required to send data on your behalf. And finally, in terms of the how, we will receive and respond to any requests for information on your behalf using all the required standards for the transactions. And we also currently support all the requirements to properly match the right patients to these requested records. Now I'm going to highlight our 2 flagship services through which most of our users will experience these capabilities. And for that, we'll go to the next slide. So what you see here is a screenshot of our main web portal, which is how most of our provider participants will choose to access that comprehensive medical history for their patient when they're preparing for instance, follow-up for an episode of care. Now, we refer to this record lookup embedded in our portal as our MX Access service. And again, it's populated with all of the USPDI data elements per the DxF requirements. So here in this hypothetical summary for a patient, you can see the labs, the procedures, the medications, and there will also be some key demographic and social and care team information that are made available to the extent that they're maintained in the EHR. And one thing I want to point out is that this record also includes unique information like filled prescriptions that are not typically available from clinical data alone, but instead come from the claims data that we're able to ingest and integrate from our health plan participants. Now, outside of our own platform, we will generate a very similar type of record, again, using that CCDA standard for organizations that request data from us outside the network. And let's go to the next slide, please. That's where our connection and our use of the national networks like eHealth Exchange come into play. After all, it's very important for other signatories to be able to query MX on your behalf so that we can get the data for those required DxF purposes to them upon request. And it goes both ways. We can and we do query those other types of systems back for information that's needed for the care teams using our platform. We can incorporate those care summaries from these other systems like Kaiser Permanente and Sutter, Dignity, and the UC system, and incorporate them into the longitudinal summary in MX Access to help complete that picture of the patient's health history. Next slide, please. Going back to our web portal, this is also how most of our participants will be able to receive and act upon those ADT alerts that we provide through what we call our MX Notify service. These can be filtered through a variety of criteria. You can have a historical view of the encounters if, for instance, you're trying to track down patients who have had repeat emergency room visits. And it's really set up to look and feel like an email inbox. And it's really designed to be as lightweight and as intuitive as possible. So you can actually go through these alerts in your workflows for care coordination and for follow-up care. Next slide, please. So with all those capabilities, one thing I want to go back to is really how they're grounded in our nonprofit mission. Again, going back to who we are and whom we serve, we really mean every type of DxF participant that has a need for a QHIO partner, regardless of your size of your resources. And to that end, we do not charge any fees to ambulatory providers like clinics or individual practices. To advance our mission to provide every healthcare organization with information they need, last month we launched the California ADT Network, which is a no-cost ADT exchange system to help all DxF signatories share ADTs. That means hospitals, health systems, skilled nursing facilities, and other QHIOs can sign up for the service to send and receive basic ADTs for free without having to join or pay for the broader suite of MX services. So if you are, for example, a hospital system that's currently on the sidelines trying to figure out how to especially comply with the DxF ADT requirements, I highly encourage you to reach out to us for more information on this new option, which we're very excited about. Now, trust is the foundation of any effective data sharing partnership, and we have very strict governance policies in place that limits the use of the patient data on our network to treatment, payment, healthcare operations, or public health as defined in HIPAA and the DxF. And we do not, and we will never monetize or sell data to third parties. We've covered our data security and reliability credentials, and they are strong to the effect that we have actually had the privilege of supplying critical data infrastructure to the state of California. Next slide, please. So I've talked a lot, and I think really the most helpful view by far can come from our partners who've actually joined the MX network and are actively using our services, which is why I'm so glad that my friend Justin Ash is here to chat with us from the perspective of his organization as a valued participant on the MX network. So Justin, why don't you start by telling us about yourself and Choice Medical Group?
Oh, sure. We've got a slide as well. So Choice Medical Group, we're a full risk entity. We actually manage about 45,000 or so patients in various counties across Southern California. Riverside County, San Diego County, Riverside, Los Angeles County, up north in Fresno County. Being a full risk entity, we take on professional risk as well as institutional risk. And so we are always looking for quality tools that can help us to integrate our network. Internally, we actually host our EHR system. We currently use the Allscripts Veradigm professional platform, and about 90% of our PCPs use that platform. And so for us, having a interoperability system, a partner such as MX was very important. For one, in order for us to get real-time ER and admit data, as well as to be able to see a whole longitudinal record. So yeah, that's a little bit about Choice Physicians Network.
Awesome. And can you remind us for about how long has Choice been partnering with MX? And really, how did Choice come upon the decision out of obviously a whole landscape of potential partners to join MX as a QHIO?
Yeah, Felix. So we've been a partner for about 8 years now. We initially signed up back in 2016 and started sharing data basically from our EHR system first. One of the main reasons we chose to go with MX, we previously partnered with another company, but they didn't really have the governance in place that we wanted to have, as well as the high trust certification wasn't available, or they didn't have it at that time. So really, those were some of the main benefits and features. And then also, we kind of felt that MX was going to be a partner here, especially in the California landscape, which, you know, we have our own unique challenges. But MX, of course, was aware of those and willing to help guide us and assist, not only in the governance side, but actually speeding up the process to get the technology rolled out.
Fantastic, because like I tried to hit upon it in my overview, I think the MX value proposition is not just the technology capabilities or the tech stack, you know, which obviously we are very proud of, but the ethos and the philosophy of really making data work, you know, in the hands of the end user, the care teams that, you know, are out there trying to provide a better outcome for your patients.
Yeah, and I would just add too, once the MX became NCQA certified, that actually was a big value add as well. For us, we do report our health risk scores directly to the health plans, and we get actually rated based on our quality gaps that we report. And having a system that actually is NCQA certified, we can take your data and send it in as supplemental standard or non-standard data directly to the health plans, which is a great add for us.
Yeah, I'm so glad you brought that up, because I feel like otherwise it's so abstract to say we have something called the NCQA DAB certification. Like, what the heck does that mean? Can you talk a little bit, maybe probe that a little bit more, how that in your experience has helped reduce the burden on reporting things like quality improvement and performance for HEDIS?
Yeah, sure. So actually what we've done is every one of our quality program specialists, and even down all the way from the director on down, actually have access to MX. They're able to actually go into the longitudinal charts, look for gaps in care. One of the statements that was mentioned earlier about having full claims data and lab data, obviously that's where you get a lot of your gaps that you can actually close, right? Looking at the diagnosis and the procedures that have been done. So being able to look at a patient record as a whole longitudinally, we can actually fill those gaps quicker and deliver better quality care and then accurate data as well.
Fantastic. And, you know, it strikes me that our partnership dates back to 2016, which obviously predates the DxF and the notion of anything like a QHIO.
Yes.
Once the DxF actually rolled around, once your physician members became aware of the new state requirements, what type of transition or guidance, if any, was needed to explain to those existing partners within the MX ecosystem, you know, how they were already set up to basically not just comply with, but thrive with the DxF benefits under the new paradigm?
Yeah, so I mean, under the DxF obviously you want to be able to share social determinants of health. And that's a challenge a lot of times, even just for the EMR to actually collect that data and then actually be able to show or prove that you're actually sharing that data in a real-time way and in a secure manner. So that was really one of the value adds of partnering with MX. We're able to prove you guys have the security of the platform, as well as the tool sets, both the MX Access portal and then the Notify portal. They kind of work in parallel, right? So for example, if someone in our case management team wants to know when a member was admitted to the ER, they can look right in there. They actually get a notification in real time, probably within 5 to 10 minutes at times of when the person hits the ED. Then on the other end, when a person is discharging from the hospital, we want to get that discharge information and actually give it to the PCPs, right? So what we've done now is we actually have the full ADT and discharge summaries come down to us as CCDA documents, and we populate that or push that over in real time to our EHR system. We use another third-party tool set called H360. It's kind of our internal intermediary that actually takes those documents, scrubs them, and then pushes it directly into the EHR for us. So all that basically makes a full ecosystem that the providers enjoy, as well as our case management and quality team. They are able to use all that data.
Yes, and I'm really glad that you brought up kind of this unique bespoke example about how you're able to bring in the information that's coming to you through the MX platform and have it incorporate seamlessly into your workflows through other tools and services. And I think it really exemplifies how there is no one solution or approach to having MX, make data work for you. You can obviously use the web portal, which is, I think, the default approach for the majority of, especially our ambulatory provider care teams that are using our services. But you can also devise some pretty ingenious integrations, right, with your EHR systems and have it come straight in through that interface, which I imagine is something that a lot of your providers really appreciate.
Yeah. And I
and,
would
and
say,
yeah,
initially, we did start off with just the portal piece, the MX Access, for a number of years, and that worked great. I mean, the providers just being able to look in and see a hospital chart, see what procedures were done, what imaging was done at the hospital, that was, spot on. And then later on down the line, maybe close to 2 years ago, we actually went the next level, right? And started the EHR direct integration, which has been even a bigger game changer for us.
excellent. Yes, that is really, really cool stuff. And I know that as we try to push the frontier of bringing in more types of not just providers in the traditional sense, but other stakeholders into the fold, as is envisioned under the principles of the DxF, there's a lot of questions as to how you would get data from a platform like MX if you don't even operate an EHR, if you're, for instance, a community-based organization or a social service provider. And I think a little bit of an aside, we want to really highlight that we are really ready to work with you and meet you where you are to get you the information that you need for your purposes in terms of your current capabilities. If that means setting up something as basic but as secure as an SFTP protocol to get you, for instance, data in a flat file format to help you work with health plans or provider groups for CalAIM care coordination, we can do that and we will do that. But what you're describing, Justin, is really, I think, a great example of kind of the cutting edge of what's possible in terms of seamless integration. I want to stick with the ADT example for just a moment, because I think it also highlights kind of the vision and the execution of the DxF goals. Could you maybe talk a little bit about, in the pre-MX era, what the challenge was in trying to get these types of alerts from all the various hospitals that your providers would have patients being seen at, right? And who they would need to follow up with for discharge, and how things changed, how life changed once MX was able to provide you with the notified service.
Yeah, before MX, it was a lot of, manual processes, a lot of legwork behind. I mean, monitoring a fax server, hoping that the fax comes in, trying to match the fax up with the right patient, things of that nature. And then also trying to get direct access to the hospital systems. Sometimes they did have their own portals and they'd allow us to, but then of course that opens up their own security rules that you have to match up against, things of that nature. And so in those days past, we would, of course, would use those faxes, things of that nature. But ultimately, once we moved over to really using MX and be able to actually go out and grab the discharge summary ourselves or look at the lab reports ourselves, and then go to the next level of actually pushing that in real time to our case management team, it definitely not only reduced costs because of the labor involved, but also it just speeded up the process of being able to help the member. Our group personally, we have a requirement that whenever a member discharges from the hospital, we have to have a nurse do a follow-up within like 72 hours, right? And so a lot of times what would happen is just trying to wait to get the discharge summary from the facility, you'd already be, a day, two behind in that process. So now being able to get it in real time, at least know that they are discharging and see the orders and the meds that are already available to them, it's really helped us out. I'd say one other added benefit is the medication list. So obviously the providers, the PCPs have the meds they've prescribed, right, in their EHR, but then you always are curious, well, what happened at the hospital? What were meds prescribed? And does that align to the med adherence that they really should have? So using MX, we actually have our case management on discharge. They'll review the med list that comes from the facility and make sure that that aligns with what the PCPs know, or even the specialists we have on our platform as well. Make sure that those are coherent with each other.
Wonderful. I think what you're describing is just, the ideal, what we really aspire for, right, in terms of the capabilities and the support that we aim to provide for groups like yours to really get the most out of not just the tools of MX, but the data that's delivered, through the platform. Obviously, technology is only one part of it. There's also the soft touch of actually making providers and care teams especially comfortable and familiar with the platform. Making it kind of like trying to mitigate the scare factor of encountering a new type of technology, and
Yes.
really showing them how it actually makes life easier and helps them, manage better care both on an individual patient as well as a panel-wide basis. Could you maybe speak to how MX and Choice have been able to work together to get not just training out to your providers, but also engagement and feedback so that we can always iterate and improve how we provide that service?
Yeah, definitely. So we've actually partnered with MX. You guys have been willing to actually do presentations at our provider PCP meetings and specialist meetings. We also have a direct account manager who's great. She's helped us out numerous times. If there's been a provider that has questions, we'll join together and do a Zoom session in real time where we can share the screen. We can actually walk through the Access platform so the providers are real comfortable with it. Also, what we've actually tried to push out in our company or our group is having some access champions, right? So staff that is dedicated, that knows the module well, and that the providers can call in and get assistance when needed. And really, once they get on the platform, we try to do a one-on-one training with each provider office. And then within the office, we try to have a champion for the office, a go-to person that can correspond directly with our team or directly with the MX support team.
That's really great. So, Justin, I really wish, and we probably can speak for hours and days about just the beauty of this collaboration that dates back again many years now with between Choice and MX. I do want to check in with Bill. I see that we have hit the 12:45 mark in the hour, and we do obviously want to reserve time for people's questions and make this as engaging as possible. So I think to the extent that MX and other QHIOs are able to sign the necessary participation agreements with any other source or provider of healthcare, either clinical or administrative information, whether it is something like a Medi-Cal RX, that's something that's worth considering. That is probably something that between DHCS and the CDII is a topic for the further advancement of the DxF and the capabilities of QHIOs. Right now, I think it's safe to say it's an open question, where there's a will, there's a way, and I don't think anybody on this panel would disagree that the more data is integrated into that comprehensive record shared between QHIOs, the better it is for the patient.
Okay, all right. Lisa, would you like to tackle the question about subscribing to more than one QHIO?
Sure, I'm happy to tackle that. So the question, as I understand it, is an organization, can I choose to partner with more than one QHIO? Do I need to connect to more than one? And we oftentimes hear this question from providers who are operating in more than one county, or maybe they are in a service area that borders other states. Certainly, you can partner with more than one QHIO, although there is a cost associated with each connection point. So that's something your organization will likely want to take into consideration. Ultimately, the state does expect all the QHIOs to partner and be able to exchange data together. So we do anticipate in the future the need for connecting with more than one QHIO will be limited because the expectation is we're going to build that capacity over time. Some of the reasons we see currently for why organizations may choose to partner with more than one QHIO is largely due to the types of data that they need access to today to support their patients. Some providers are seeking access to, say, for example, county behavioral health data and the like. So this is one of the reasons why we encourage everyone to really take a moment, talk internally about the types of data you're seeking to exchange with, and then talk to your QHIO partners about what they can do now versus what they have planned for in the future.
Okay.
Felix, anyone else? I welcome others to add to that too.
Okay, Felix, I have one for you. So does Manifest provide being part of an e-health exchange to provide data for patients on ADTs across the entire nation, or is that that new service only limited to California?
Yeah, thanks, Bill. So I'm glad the slides are going to be provided at the conclusion of the webinar, because one of the slides, that if you remember, that I hit upon, kind of had a list of some of the health systems that we are currently actively querying for clinical care summaries. When one of our patients, not our patients, of course, but one of the patients who is otherwise being served by an MX participant has an episode of care that overlaps with those other systems. So those systems are really limited to ones that are operating in the state of California at this moment. Kaiser, Memorial Care, the UC system, obviously, Sutter. And I want to really make the important distinction that the data we're bringing in are not ADTs per se. They're triggered by a hospital event, but what we're really incorporating from those other health systems through eHealth Exchange is the clinical care summary that is part of the overall patient history. So eHealth Exchange indeed is a nationwide network, and we are queried on a daily basis from organizations inside and outside of California. But for what I talked about in terms of bringing in data, right now that's really limited towards those California-specific, large major health systems.
Okay. And then Susan is asking whether MX is planning to support adding CBOs or CommCare hubs in its data exchange networks?
Yes, certainly CBOs are part of our active discussions, and we're excited for what the future holds. Leave it at that.
Okay, great. Can we answer another question from Susan about the percentage of SNF and post-acute data that you're processing across the California network?
I will take a mulligan on that one, and because it's an important question, and promise to get back to you with
Okay,
that.
you know where to find Susan, so that's easily taken care of. So there's a question for Justin from Bill Quinn about the name of the program that Choice uses that you referred to, Justin, to auto download data from MX into your EHR.
Oh, sure. So full disclosure, MX will allow you to get FTP access to the CCDA files. But what we chose to do is we had a third-party vendor. It's called H360. And I don't mind, I can share the contact info in the chat or after. But yeah, we just partner with them to actually integrate those feeds into our EHR system. So it's called H360.
Okay,
H360.
H360, okay.
Mhm.
All right, and then one final question. Does Manifest support interoperability by supporting bulk fire in addition to current CDA approach, which needs an SFTP interface?
The answer, short answer, Bill, is yes. It is something that is on that we have a capability for today that we've deployed in some instances through a Fire API endpoint, and it's something that we're actually very excited about in further evolving in specifically our 2024 product roadmap. You will see us hopefully very soon announce some exciting new developments working with especially our health plan partners to get them this type of information as FHIR becomes a more commonly adopted standard, which is obviously something that we're very aware of and very responsive to.
Okay, and let me close out with Martina's question here at the end. We're at the top of the hour. If you are already an MX user and you've already signed the data sharing agreement, what is the next step for you?
The next step, if you have not already, as simple as it sounds, is really fundamental. Make sure to work with your customer success representative on the MX team that your CTDA and other clinical data feeds are up and running and live, because that, in the end, is the sole marker for whether you are complying with the DxF. It's not necessarily whom you've signed an agreement with on paper for a QHIO, it's whether you're actively contributing the necessary data feeds to make that data available upon request.
Great. Well, I want to thank all of you for participating in the panel today. I want to thank all of the audience for your questions and your attention. We really hope that this has been helpful to you. APG, Transform Health, and Manifest MedEx, and our member Choice are very supportive of the rollout of the DxF across California. We want to put more information into the hands of patients and providers as we move forward in the implementation of the DxF. And we want to thank you all for your participation today. So have a good afternoon and the rest of your week, and thank you.